So next, I am excited to introduce Dr. Chuka Emezue. Dr. Emezue is an assistant professor in the Department of Women, Children, and Family Nursing at Rush University College of Nursing. He holds a PhD in nursing, a master's of public health, and a master's of public affairs, all from the University of Missouri Columbia. His research applies digital and behavioral health programs to improve the health, economic stability, and prospects of boys and men impacted by co-occurring violence, substance abuse, and mental health disorders. Dr. Emezue has worked on research initiatives with government and civil society organizations, including UNICEF, the Brady and Ann Deaton Institute for University Leadership and International Development, and the UN Millennium Development Goals. He's the founder of the Brotherly Act Project, an initiative focused on leveraging technology, career navigation, and mentoring to heal, humanize, and empower violence-impacted youth to lead and enjoy values-based lives. He's here talking about reimagining trauma and equity-focused support for boys and men on both ends of the gun.
Hello, everyone. Good morning. I'm glad to listen to Dr. Raham lay me off for my presentation. Because I'm going to be talking about youth violence specifically today, focused on young Black men. I am a violence prevention researcher, and I'm kind of can you hear me? Can you hear me in the back? So I do violence prevention research, and I started out working with women and girls who were survivors of violence. But we found out pretty soon that there weren't enough interventions for the men who perpetrate violence. And violence is such a hard thing to change once it gets into adulthood. And so I spent much of my time focused on the men and boys who use violence. I want to start out by saying I have no conflicts to disclose, financial or otherwise. This is my village. I always like to put this slide up to thank the people that have helped this research get to where it is, especially our community partners. Some of them without alphabets behind them, letters behind their names, but who do very wonderful work in the community as well. And then our funders too, some in the room very graciously have helped different aspects of this research as well. So in terms of looking at violence, I think we know, what violence looks like. This is Chicago. We've heard of other cities like Detroit, Oakland, California, and the extent of youth violence in those places. But I wanted to talk a little bit about violence during and after the pandemic and how that has changed and what the picture looks like. When I talk about violence, I'm specifically talking about pediatric and youth violence. So violence impacting those ages. Is it doing the scratching? They can't hear me. Okay, I can hold it. Is this better? Put it to my face. All right, so we're talking about everything from bullying all the way to gun and gang-related violence. Here I have a few slides and charts to show kind of like an upward trend. No surprise there. When you look at figure 1, you see in terms of children and adolescents, firearm-related deaths from 100,000. Look at that big uptick in 2019 during the pandemic. When you look at the other slide, it's broken down by, in this case, sex. Unfortunately, most of the data I'll show today collected binary sex. But you find that with young men specifically, the bar chart just kept ticking up from 2018 all the way to 2021. Firearm remains the leading cause of homicides amongst all youth. When we look at Black youth in particular, firearm is the leading cause of death, and I will show from those aged 10 to 24 is the leading cause of death. But when you look at homicides in general, for those aged 0 to 44, it is the leading cause of death too for that. For young Black men, I'll show you, I'm going to bring it down to Chicago soon. But when we look at racial and ethnic minority groups, especially young Black men, it's sort of, you see the bar chart for the Black youth right there. It is set at the national average at 12 per 100,000, especially for young Black men, and especially in 2021. So, like I did say, firearms remain the leading cause of death. Young Black men are 24 times more likely to die from firearm-related homicides. I want to make a distinction between firearm mortality and firearm homicide. So when we say homicide, we're talking about intentional death, murder. When we say firearm mortality, that includes everything from suicides to accidental firearm discharge and the like. So for firearm mortality, young Black men are 4.3 times. They have a higher rate of 4.3 times compared to white youth. When we come to homicide, anywhere from 14 times higher than white youth. Of course, the worst psychological effects, psychosocial, biological effects are accrued to young Black men on account of these experiences. But at the bottom of the slide, this is very key information. We call them trauma recidivists sometimes. But you find out about 50% of young Black men who survive a penetrating injury will return to the ED, the emergency department, for a similar injury within 5 years. And about 20% of that group will die, unfortunately, due to firearm-related assaults. This was that chart I was talking about. This is not recent. The most recent that the CDRP put out for leading causes of death for young males was in 2018. So you see from age 1 to 44, homicides are the leading cause of death. When you look at the very last column, you will see that homicide still ranks in the top 5 causes of death for Black males of all ages. I'm going to go past this slide quickly, but what I want you to take away from here is that while we're also talking about homicide related to violence, we're also seeing an upward tick in suicide rates related to gun use, so gun inflicted suicides. Also ticking up, not quite as much as homicide rates, but there's an uptick specifically in suicide rates using firearms. I also do early substance use prevention work too, and I wanted to put this in there to show the overlap between substance use and violence. We found that about 700,000 urban youth typically show up to emergency departments for assault-related injuries. About 20% of that group reports having used some kind of substance in the 3 hours preceding the injury. And we also find a higher level of substance use when we talk about partner violence as well. The colorful bar charts there are looking at the breakdown by, in this case, sex as well. But I want you to pay attention to figure 2, looking at a breakdown for drug overdoses by racial and ethnic groups. Now we see that the highest percentage for drug overdoses lie with white youth. But when you look at 2020, the chart in the bar in the middle, you see that while the percentage is decreasing for white youth, it's ticking upwards a little bit for Black youth and Hispanic youth as well. Now, there are very many risk factors. I wish I could move this. So I'm not going to dwell on this slide. I think we know that the risk factors for violence and substance use have a heavy overlap. They're multifaceted from the individual along with the societal level. Some of the things on this list may stand out, and this was put out by the World Health Organization in 2017. But I wanted us to look at some of the outcomes or the effects of violence on health. It transcends multiple levels. We often think about the injuries. The mental health is also one of the things we think about. But we don't think about the communicable diseases, and we don't think about the non-communicable diseases, heart disease, diabetes, so on and so forth, that sort of linger across the lifespan based on various direct and indirect violence experiences. So, the topic did sound a little sensationalized, talking about young boys and men on both ends of the gun. I wanted us to sort of visualize the trauma of being both a witness, a victim and perpetrator of violence at the same time. And I will show you some data for them collected in Chicago that shows many of them occupy this multi-faceted role, having witnessed violence, having been victims of multiple forms of violence, and having perpetrated violence. So, homicide survivorship is something that we don't talk about enough. Many young men, young Black men specifically, by the time they get to age 24, will have experienced an average of 3 deaths or losses related to homicides or other multiple causes in their life. Imagine going through life with this kind of trauma. So, what are the patterns and strategies utilized by racial and ethnic minority youth when seeking supportive services? So, we have a clear picture of what the problem looks like. Let's talk a little bit about some of the solutions out there. We took this data set collected by the CDC called the Adolescent and Behavioral Experiences Survey. It was a one-time survey collected in 2021. It sampled about 8,000 US high schoolers from 9 to 12. What we did was we extricated the racial and ethnic minority youth, wanted to understand their violence use patterns, substance use patterns, and then how they were seeking out help and what kind of resources they used. We looked at victimization, pay attention to the very last column. Some of the outcomes we looked at specifically were victimization, perpetration. We also looked at family violence, which we found spiked during the pandemic as people were locked indoors. We also wanted to look at substance use and a dependent outcome. In this case, we were comparing all of those things to how this high schoolers use telehealth services for mental health support. The table on the right, really briefly, I'm going to say we did not find any difference in telehealth use by age or sex or ethnicity, but we did find significant differences by race and by sexual identity. I'm going to show a breakdown of what that looks like shortly. So in the very first panel, telehealth use was really high amongst the multiracial group. And I will be honest with you, with the CDC, this multiracial group seemed a little bit ambiguous. So sometimes you find that spiking really high for various things. But high telehealth use for mental health support with that group. When we looked at panel B, you can see that the substance mostly used was cigarette, tobacco, followed by e-cigs, which is also spiking up as well since the pandemic. But overall, we found that those who use substances, those who reported experiencing care and family violence, also had a significant likelihood of using telehealth for mental health support during the pandemic. Surprisingly, this surprised me. We had to run this data a few more times to figure out, the third bullet point if it ran true. But we did find that, young racial and ethnic minority youth who reported carrying a gun had 4.8 times, almost 5 times higher odds of using telehealth for mental health support. And there are various reasons we can now think of for why that is. We found that those who were in physical fights and who carried a weapon, in this case a gun, knife, or club, on school property, also had a higher likelihood of telehealth use for mental health support, as well as those who use various illicit drugs and substances. So clearly, telehealth use seems to be a very wonderful resource for this group, not only based on substance use particularly, but for those who also experience violence as well. So that was submitted somewhere to get published. But we want to talk about Chicago specifically and what the picture looks like with this. So as part of a clinical trial that we're conducting, we collected violence and substance use data from young Black males aged 15 to 24 on the west and south sides of Chicago, about 266 of them in that sample frame. The mean age for this group was a little over 18. Most of them, of course, were Black. So most of them had some high school, most of them were single. We collected that information because we're going to talk about relationship violence as well. Most of them were students in terms of their employment, and most of them had a smartphone ownership. Because I'm a digital health researcher, it was important to collect that information. But when you look at internet access, that's a completely different picture, very different from smartphone ownership. So in short, about 54.2% of them said yes to being impacted by some form of aggression or violence in the past 12 months. This is a catch-all question because we couldn't ask directly if they had perpetrated violence. That strategy did not work. But we also found that, like I said, physical violence was mostly occurring. About 66% had been in a physical fight at least once in the past year. Partner violence was concerning and worryingly high. About 30.4% of them said they had perpetrated some form of partner violence, especially psychological abuse. We also looked at the risky firearm behaviors and found that 20% of them had carried a firearm 2 to 3 times in the past 30 days. And almost the same percentage reported threatening someone with a weapon in the past year, and a very high percentage. Think about that Venn diagram I showed you, and those people that have been experienced with witness, perpetration, and victimization, was 73% of them fell into that category in that group. In terms of their substance use profile, binge drinking, about 20% reported binge drinking, which we measure among males as more than 5 drinks in a session or in a row in the past 30 days. We also found that about, looking at the bottom bar chart here, about 40.2% reported having perpetrated violence or aggression after taking drugs or alcohol. And another 40.2% also reported, I think that number is the same, but a similar group also reported using medication or drugs that were not prescribed for that. So, what works specifically? The CDC put out this table, which is a meta synthesis of what we know is effective for violence prevention. So looking at various programs across the nation. There are several, these are very abstract terms, very big focus strategies, but they have approaches that have worked. What we did was we took out 2 approaches, 2 strategies here, specifically trying to strengthen youth skills and trying to lessen the harms of violence and prevent future risk, which is why we work with a younger age group. And we do everything from research to, what I call research. I got fed up of, having focus groups and handing them gift card and saying, sayonara, be on your way. But we had to figure out ways to engage this youth a little bit more intentionally. And so we have a boot camp that we put together with high school youth for 3 months. They will get paid, and they will advise our research directions, some of the strategies that we are using. We also organize a youth boot camp with leadership, entrepreneurship, and technology skills training. We have 28 adolescents in the room, mostly males, because we did start out targeting males on social media. But, parents and young girls were like, "What about us?" So we made it gender agnostic, and had about 3 young ladies in the room. Our community members continue to advise us, when we think about reimagining how we do violence prevention work. They continue to advise us on, everything from what kind of gift cards we use, when we organize our sessions, what our recruitment strategies are, data collection materials, and so on and so forth. And so we set out, taking all of this into consideration, to develop a digital intervention called Brotherly Act. Specifically was a skills, we started out a skills training intervention, an intervention in your pocket, a take-home intervention, whatever you want to call it. And it is focused specifically on reducing violence and substance use, using various adaptive skills. So we're not focusing on violence, as some of us may know. When I talk to this young men, they know that the violence is bad, they know that substance use is bad, but what next? So we're trying to take them to a stage or a step where we connect them to trusted resources. We'll connect them to trusted resources, educational resources that they can access on their own. And so it's a 3-phase study. I'm not gonna go into specific details. We've spent the past 2 years doing some formative research, so speaking with various groups of young men. I think at this point we've had about 55 of them in both focus groups and individual interviews. Talking to them about, hey, if an intervention existed on a smartphone app, would you use it? And if you will use it, what kind of content would you want to see on that intervention? And so I talked about this formative research. Various themes have come up. You know, I'm a mixed methodologist, and so I also love my qualitative research. That's where the gist is. We did find, like I said, many of them are well aware of violence. They were born into it. A very high level of helplessness and hopelessness amongst this group. On multiple occasions, I've had some of them say that they're more afraid to live than they are to die. And you know, there's a very high level of service avoidance, emotional avoidance, so opting out, showing up late, disengaging from formal services that exist. It is a conundrum. Chicago is a program-rich city, but we have a high violence burden. And it's the same thing when you look at other cities where there's a high violence burden too as well. It's an optic issue. So not a lot of people are trusting the systems, and not trusting us as researchers, and not trusting medical systems or legal systems. These are some quotes. I'm not going to read them. I'm just going to skip that really quickly. So part of the intervention, you know, is it's supposed to be a brief intervention. So we can deploy this anywhere in an emergency department, in the school system, as part of a diversion program to support young men at home, something they can take home to address some of those barriers we talked about, like stigma and distrust. It's youth endorsed. It's, you know, the idea is to support those who are treatment curious, all the way to those who are treatment veterans, to those who are already adjudicated in the system. It has a harm reduction approach and harm reduction lens. For those of us who are theory wonks, the broadly active intervention has 3 components. Simply put, psychoeducational modules, about 7 of them. Each module uses a micro learning theory approach, so they can complete the module in 5 to 7 minutes. We have a safety planning toolkit with various tools from goal setting to mindfulness-based stress reduction tools. And we have a service engagement AI-powered chatbot. And all of this, of course, is based on the acceptance and commitment. And you know, the acceptance and commitment therapy is a trans-diagnostic therapy. It is in some ways the cousin of the cognitive behavioral therapy. And that nice spaceship-like looking image is the 6 core principles of the ACT therapy and what we're trying to address. We're trying to take them from being in the red to being in the black. We did adapt for the educational modules I talked about a program called Achieving Change Through Values-Based Program. It's a domestic violence program designed for men and women in incarceration. In that program, multiple effectiveness trials have shown that it is effective at reducing criminal behavior as well as domestic violence. How about we try to adapt that? We use violence and aggression for those who are not educated. So we spend a lot of time with the researchers who design that intervention to adapt it for this population and for digital delivery as well. I have some snapshots, of course. I've been talking about this for a while now, but this is what it looks like. Kevin Durant's not part of our research team. We do have, that's one of our safety features at the bottom of the screen. The orange button is a quick exit button. When they click it, it takes them to an ESPN web page where it can take them to a web. And there's several reasons why this is very needed. And of course, they need a PIN code to sign on to this. If you put in the PIN code twice, and wrongly, it will dump all the data you have to put on the app and just be a brand new app. We also have a risk assessment. This is a screenshot of someone trying to assess their risk for one violence. You can toggle the sliding bar and it populates a risk score that we can address on the app using the modules that we already have, or push you forward to the chatbot and I'll show you what that looks like. We have some load tracking functions and features. I know my time is getting close. But if we can train your mood using emojis only over 30 days, and then we'll give you recommendation based on how your mood has looked like, and for what specific reasons your mood has looked like that over a month. We also have the chatbot-based function to triage you to local resources. Right now, it's set for a 50-mile radius of Chicago, and we're trying to vet the resources. Some websites are no longer working, some phone numbers nobody's picking up. So we're trying to pull all of that and clean that up to put on the intervention as well. There's a smart goal feature you can track. One something with marijuana, you can track that as a major goal. Multiple sub goals under that to reduce that behavior over time. And we're trying something new. We have parents asking for intervention for 13-year-olds, 11-year-olds, 12-year-olds. So we're going to try to include a comic-based version on the app, see what it looks like. I may come back to talk about whether or not this was a bust or whether it was good. And we submitted some grants to take this to the emergency department to do a clinical trial across 3 emergency departments. And several limitations. I'm not going to go to this, unfortunately, the time is coming to an end. So to get some Q&A. But several limitations in terms of, we have programs that work. Becoming a Man is a wonderful program in Chicago and across the nation, actually. Working on women is a wonderful program as well. But those programs cost some money. It may be possible to address the costs for some of these programs in digital formats or remove this intervention. I should also say that early action of trying to replace for one of the programs that are already going on in Chicago, trying to augment it. If someone is, wakes up in the middle of the night, a gang member who's involved in something, want to be able to connect them to a peer mentor in the future easily and quickly and reliably using this kind of format. Some gang members and some people involved in bands do not get on a train or a bus to go downtown, wherever, to get services. It is fundamentally unsafe for them to access those brick and mortar type services that we have. Plus, there are various policy implications. This is my wonderful group of young men, some of them on our advisory board. It's hard to interview adolescents and ask them to give you questions, to give you response back, especially the young men. But so far, we're doing a good job. We have some community champions that help in facilitate this relationship. And that's it. Thank you.
Really incredible work as someone who's also tried to engage adolescents. I know how hard it is, particularly when you're talking about topics that aren't food and aren't things that adolescents like to talk about on a regular basis. So major applause on that. We will open up to questions in the room. Just raise your hand. And then questions for the Zoom, because Dr. Latirafont is watching. I think there's a question right up here. Why don't we start there?
There. Can you hear me? Okay. Anyway, my name is Kathy. I'm from the health department. Can you hear me? Hello? Hello? I'll talk loud. I want to say amazing work. It's so wonderful. The work that you've done and you built from the research to application. So the city, we are in the health department and I'm in the Office of Mental Health. We're working really closely with Mayor's Office, DFSS, a lot of different city departments to address public safety and youth and mental health. So I would love to hear how we can scale this up and integrate it into city, initiatives, and just maybe inviting more conversation about that post presentation. But if you have any preliminary thoughts, I'd be happy to hear it.
After all, I have a business call. But yeah, I think we applied for a clinical trial early 2024, and it might be across 3 emergency departments with children recruited in that setting, and want to see what the effect size looks like, so what the outcomes look like, and what particular issues it's addressing. So we're addressing substance use violence and mental health issues, so psychological distress as an umbrella term. I feel like, based on prior work with other researchers, that the psychological distress would be the things we address that change first. The substance use will change next, and then the violence is a maybe, to be honest with you. But I can come back after this that clinical trial to talk about what the results are. There's a chance that we might break up broadly active intervention to test the individual components, so the modules, chatbot, and the digital mental health tools separately, to see if it has different effects on various outcomes. But I'll be glad to talk, today about what that might look like in the future. Thank you.
You're the brotherly act reminded me of Peter.
Moving.
Reminds me, you got a lot of amazing engagement, a lot of technology enhanced prevention. It's amazing that you're combining the two. What about faith-based approaches? What are your thoughts on that? Or what are the acts maybe somehow trying those or is that not even on?
That's a really good question, and coincidentally, with the SEEN grants, it's one of the things we are talking to the young men about, and we ask them about faith. So we try not to leave them there. If it comes organically in the conversation, then that's one of the resources they use. But most of them turn to themselves. There's a lot of peer counseling and around the lunch table that happens with them. They tell us they do not trust therapists. We asked if it was if it had anything to do with race or gender, none of those things matter to them. They were more concerned about privacy, about someone about violence having not come from their background. We asked about faith, and it did not seem to ring like a resource they turned to. I think globally we're seeing that Gen Z and young people are doing politics interactive. I'm a preacher's kid. When you go to the church, the pews are not, you're not seeing a lot of young people here. So meditative practices is what they are trying to do more now. And we're asking them, so if you're doing meditation, which I was surprised, many of them doing some form of meditation, what does it look like? Anything from sitting in the dark and talking to yourself, which we all did, one where that is, all the way to listening to particular genres of music, going on walks, if it's safe to do so outside. But not the movement type practices like yoga and those things. But they are trying, the apps, the Calm app, which I shouldn't be publicizing, but that's very wonderful. Those oddly satisfying videos on YouTube, those are some of the things they're trying to positive things to turn into that stuff, but it doesn't really work stuff like that.
There are questions about the Zoom.
There is a question from the Zoom. There's a common question. I think there's one about looking for a company to develop curriculum in comics. And so I think I'll connect the two of you to that person. And then there's a question about the sustainability and future direction of your work. Those would look like. Maybe you talk a little bit about that, maybe more detail.
In short, well, we're gonna adapt it for other people. So Hispanic youth, we're gonna adapt it for young females, we're going for the Sisters Act. And by the way, the ACT is all this better. But we will adapt it. We also have immigrant youth as well. It seems to be a big population that's growing in our public schools. I'm an immigrant as well, so the conversation for that group is very, very different. But we plan to adapt it with the rest of the group.
Couple more questions in the front. I think we have time for one last question. Right up here.
Oh, great. Great. Thanks. Your work's super interesting. So I think what we're doing and all of the work is great at addressing sort of the mental health and some of the things that we know maybe lead to violence, but a lot of what we know is basically that income is a huge driver. And so sometimes I have these moments where I'm like, if we just took all the money that we're using to do all of this work and gave it to people, would we actually do a better job of right? So it's like one of these things, like everyone wants these to show us like, oh, are you reducing homicide? And so many of these things like, or, it's like maternal morbidity. It takes so long to get there and with homicide. So I guess my question is, how do we as researchers and policymakers sort of address those two things of seeing the benefits of our research, measuring those long-term impacts, and then also like, how do we just advocate to give people more money?
So the question is, how do we take the money from doing all this fancy, shiny stuff to actually doing intervention and giving the money to people who need it, which is a really key issue. Some of our participants are asking specifically for felon-friendly services from this type of intervention because they can't. Many of them are trying to go out to hustle to put the lights on, milk and bread, and for their mom, for their dad. employment is a little bit of a big issue. What we try to do with our research is we, increase the amount to give, we used to give $25 gift cards, and the community partner said that doesn't do a lot, I came from Missouri, it probably does a lot in Missouri, but. So, we updated that, we updated how, what kind of gift cards we're giving them, using a MasterCard, Visa cards that they can use for whatever they want, instead of Burger King, Target, and Amazon. But in terms of long-term gainful employment, there's only so much we can do on an app, to be honest with you. I've been told that an app cannot stop bullets, but we can try with every tool in our arsenal to support these young men. One of the resources we have is connecting them to employment opportunities. We have a category based on that. And we're trying to put together a list of fellow-friendly services, especially in our healthcare village and community, that some of these young men can latch on to. We also did some entrepreneurship training to show some of the young men opportunities in nursing. We need a lot more men in the field of nursing. The stigma is fading with this new generation, so we're trying to get them in this kind of jobs.
That's awesome. Thank you.
What an incredible morning so far. Thank you, everyone.